Max Wardell, overheadathletics.com, back at you with another one in our UCL series. We're talking about UCL tears here. This one's all about assessment. If you haven't checked out our last video where we talked about UCL tear type and prognosis, you need to go back and check out that video. We're going to throw a card on the screen so you guys can go back and check that out. That's an important concept to understand when we go into assessment. If you want the Reader's Digest version here, we essentially have two components of the UCL that we're talking about. The posterior bundle, which is this section, goes from here to here. We have the anterior bundle. This is the Tommy John ligament. Remember, goes there to there. That's the component that really gets torn. So that anterior bundle of the UCL from the medial epicondyle to right there on the humerus, the sublime tubercle, is where we get torn. So basically what we're going to do to assess it is we're going to tension it. Now we will see that a lot of times guys will come in with pain here, right there, a point right there, that's where the pain is. We got to understand there's a lot of stuff going on in this area, so it's not always the ligament. If somebody has pain on the outside of the elbow out here, we want to take note of that, because if you gap the inside, you compress the outside. So if one side opens, the other side compresses. So what we're going to do here is we're just going to start with a little bit of palpation, see if they're tender. If it's really hot and inflamed, just using a thumb pad, we can sometimes elicit some symptoms. We want to see what we feel. If palpation bothers him, we're going to be thinking more about the muscular components or even the nerve, the ulnar nerve, which tracks right through here. But if palpation doesn't bother him, but he has pain when his arm lays back in the throw this way, we are thinking about the potential of this UCL. And what we like to do is just take him into a position where we kind of wind up his external rotation. I like to do it on the back first. Turn the forearm this way a little bit into supination. And then once I've got a little bit of tension on it, I take up the slack and then I give him a brisk thrust. And if somebody has a lot of play in their shoulder, or really loose shoulder, or shoulder pain, and I'm feeling it here, and I can't get a good feel if it's lax or not, because what I'm trying to do is I'm assessing if there's a lot of motion in the joint. If it reproduces it, I know right away that's a positive test. However, if I am not getting a positive test and I'm not getting a good amount of torque on it, which you should be able to if you take up the slack, I can take him down here and I can apply the same thing right here, because this will lock the shoulder. And I can take up less slack to get to the end of the shoulder range. I hold here and I give an equal and opposite force. Remember, I'm in a little bit of supination. 70 degrees approximately of flexion, and I give him a nice brisk force there. If I want to assess in another position, I can take him into extension, assess here, or I can have him sit up. So let's go sit up. And this is the one that most of our physician colleagues use quite a bit in the clinic. I can take him here, once again, wind him up. This may be the most reproducible if you haven't done a lot of these assessments. Wind him up, find that position where I've taken up all the slack. I've got him biased into supination, approximately 70 degrees of flexion, and then I give an equal and opposite brisk force. If that reproduces his symptoms, or if I feel like it's soft in terms of I can continue to push and it doesn't give me a brisk, firm stop, that's an indication that he has a UCL tear or some form of UCL damage. And a lot of guys, especially our young guys, we can compare side to side. Now understand, he's not going to have as much external rotation on this side as a throwing athlete, so I won't have to wind him up as far, and I may expect to see a little bit more laxity or softness on this side. But if it's significant where I can really feel the difference, that's an indication that he has an ulnar collateral ligament tear. Now, I get a brisk end stop when I hit chuck. It definitely gives me a stop firm feel, and that's good. That means his UCL is in good condition. Might not feel great for him, but if I compare side to side, say, does that feel different? And it does, that'll give me an indication. Now, likewise, and this was my point early on, if he gets some pain on the outside of his elbow here, we want to think about compression of this lateral side of the elbow, which we're going to utilize in our manual therapy technique. So once I've kind of hit him there, then I'm going to say, all right, let's just make sure that we don't have any sort of ulnar nerve involvement. The ulnar nerve is tension when you take these two fingers into extension, you take the elbow up, and you have him go into this position. You can have him depress his clavicle, see if that elicits his symptoms. If it doesn't, I can have him side bend. If somebody's really hot and exacerbated, we're going to do this sequentially, so lay on your back. We're going to start here. I'm going to extend the fingers and the wrist. Then I'm going to bring him up into abduction. Rest him on my hip there on the thigh. I've got him into extension. I'm going to depress. I'm going to slowly flex him in. If he gets pain, I can back off right away. If he doesn't get pain, I can take him all the way in, take him a little bit further into abduction. Still doesn't have anything, I can have him side bend to the left with his neck and rotate. If that gives him symptoms in the elbow or in the hand, great indication that he has a little bit of a tension-sensitive nerve there. And I can always come over to the other side, say, turn your head, side bend, same or different. If it's different, that gives me an indication that something may be going on there, nerve-related, to differentially diagnose. If I'm still a little bit confused, maybe it was a little bit lax, a little bit of pain, I can always come back to look at the forearm musculature, and I'm going to grab him here. He's going to grab me there. Now I'm going to say, Chuck, don't let me turn you this way, and you're going to try to turn me this way. So I'm having him try to actively pronate, go. And if that reproduces symptoms, there's no valgus stress here. It's a great indication that he probably has a little bit going on with his pronator teres muscle, which once again attaches in the same area. Likewise, I can do some finger or muscle length assessments, which should not reproduce elbow pain if he has a UCL injury. Generally, it's pretty apparent when somebody does, but you're not always operating with the benefit of imaging. So I assess flexion, I assess extension. Oh, he's a little limited in extension. That's something to take note of when we move into the next steps of the process. But manual muscle testing, grip strength assessment, squeeze as hard as you can. If these things reproduce pain at the elbow, those are good indications that we're dealing with something more forearm related or more muscle related as opposed to the UCL. And also location is important. Pain here versus pain here is very different. Pain on the top side, into the muscle belly, into these tendons, these flexor tendons as they come down are valuable information when we think about UCL tears. Pain up in here or pain with resisted tricep loading may indicate, may indicate tricep issues because this, should not reproduce UCL pain because I'm pushing him into elbow flexion with no added valgus stress. And remember, those tricep tendons come into this area. So it's not just give him a valgus assessment and say, oh, it's all good. Let's assess all things. Let's rule things out, rule things in. Manual muscle testing the triceps is often neglected but very important. Muscle length testing of the forearm muscles, often neglected, often important when you're going on physical examination only without the added benefit of having imaging. And I think even if you do find a positive UCL test where, hey, right away I feel there's no firm end stop with valgus test and it reproduces pain, he's probably got a UCL tear, sprain of some sort. But I think it's always important to look at some of the muscular components, do some palpation, and then still look at the nerve component because a lot of these individuals will have nerve involvement as well. So a lot of things to start to think about there, to wrap your mind around, but that's how we start to assess the UCL in the clinic in a pretty efficient manner. If you like this video, make sure to hit the thumbs up, subscribe, because this is the second part in our UCL series. We're going to come back in this 5-part series. We want to talk about manual therapy, we want to talk about throwing interventions, and we want to talk about exercise. So subscribe, hit the bell for notifications so you do not miss those videos. And if you haven't yet, go back to our first one on different types of UCL tears so you can get a better idea of prognosis of UCL tears as well as how UCLs begin to become torn.